Okay, the second chapter is hematology, and when you first start it, it talks about like primary hemostasis and achieved by whatever. Okay, here's what you really need to know. All right, what are the three initial responses to vascular injury? Number one, vascular vasoconstriction. Makes perfect sense. Number two, because you want to decrease bleeding. Number two is platelet adhesion, and number three is thrombin generation. And how does platelet adhesion happen? To be very precise, platelet adhesion happens. Obviously, the collagen in the injured vascular tissue is exposed, and then platelets bind to that. And when platelets bind to that, it releases some stuff. We'll talk about everything, and then more platelets come up, and then a plug basically is formed, and it stops the bleeding, or it stops the injury. So, right, when you talk about normal coagulation, right? So you have the vascular vasoconstriction, you have the platelet adhesion, you have the thrombin formation, or thrombin generation, sorry. And you want to know there's two pathways for the activation of coagulation as we know it. You have the intrinsic and you have the extrinsic. The intrinsic has everything in it, right? It has 12, 11, 9, and 8, right? And then the extrinsic is has one basically in it. You have tissue factor, obviously, and you have factor 7. Basically, both of these come down into one pathway, and the whole point of like the extrinsic and the intrinsic is to activate factor 10. That's the only thing that's important to them, right? So 12, 11, 9, and 8, as well as tissue factor and factor 7 are just trying to activate 10, right? And once you activate 10, 10 activates 2 through the help of 5. Don't get too confused. Just remember 10, 2, 1, right? 10 activates 2, 2 activates 1. Okay, and basically you have 10 activating 2, 2 activates 1. So 10 activates thrombinogen into thrombin, and then thrombin activates fibrinogen into fibrin, right? So you have 10, 2, 1. The cofactors you should think about in terms of the intrinsic, the most important ones, you obviously have the exposed collagen, doesn't matter, pre-kallikrein, I don't know what that is, just a lot of kali, a lot of kininogen, all that stuff. The important ones you should know about is, for the intrinsic, it includes everything, so that's 12 activating 11, 11 activating 9, 9 through the help of 8. So you have 2 through the help of basically like cofactors. It's 8 and 5. 8 helps 9 activate 10. So 9 activates 10 through 8, right? And then you have 10 wanting to activate 2. Remember, we said 10 to 1. 10 to 1 is 10 to 1. In order for 10 to activate 2, it needs the help of 5, right? And these are the important ones you should know about. Extra notes you should think about. Actually, you should have like memorized, I guess, because it's very important and it will help you a lot when it comes to questions of medications and PT, PTT, heparin, warfarin. Just remember, heparin, like when you think about intrinsic, it has all of them. So it has more factors. Which one has more letters, PT or PTT? PTT has more letters, right? And PTT comes with heparin. When you want to increase PTT, you give heparin. On the other hand, PT is extrinsic because it has less, and it comes with warfarin, right? So these are the important parts you should keep in mind. Okay, so when you think about the prothrombin, now you have to talk about prothrombin complex for intrinsic and extrinsic pathways, both. But prothrombin complex basically is 10, 5, 2, and then calcium and platelet factor 3, right? So 10, 5, 2, calcium, platelet factor 3. The way you remember prothrombin complex is like PTC or PCC. I remember it as PTC because somehow T is like close to an X for me, so it's multiplication. 2 times 5 is 10. But that's just the way my weird brain works. The important thing about prothrombin is that the prothrombin complex is that, actually we'll talk about it later, but it catalyzes the formation of thrombin, right? As in thrombin is what? Thrombin is 2. So the most important part of the prothrombin complex is 2, and it has calcium. So tissue factor pathway inhibitor inhibits factor 10. This you should know it. Fibrin, the important part of fibrin is that it links platelets together, right? So when you form the fibrin clot, it's literally plates connected together by fibrin, specifically the connected through the GP2B3A, right? So you have the GP1B. The GP1B connects kind of like collagen to the first platelet that comes, and then with the help of von Willebrand disease, von Willebrand factor, and then that's GP1B. GP2B3A helps cross-link basically platelets and form the platelet plug. And an important thing you should know is that, you know how we talked about cofactors, like things that help? So not 8 helps 9 to activate 10, 5 helps 10 activate 2. So remember this 3, like 10, 5, 2. This is all prothrombin complex, right? Then you have 13 helping 1 activate nothing in specific, because 1 doesn't activate anything, but cross-link the platelets together, or the platelet or the fibrin clot, right? Sorry about that. You have the thrombin, the key to coagulation. It converts 2 into 1, 1A into 1. 1A is basically fibrinogen, 1 is fibrin, inactive/active. And thrombin activates factors 5 and 8. Remember how we talked about the cofactors, 5 and 8? 2, which is the thrombin, activates 5 and 8 as well. All right, so we talked about that. Let's talk about normal anticoagulation. We talked about coagulation, right? This is where everything clots together. We need something to counter that, because we don't want everything to clot together all at once. And the biggest anticoagulant in the body naturally is called antithrombin, or antithrombin 3. It's the key to anticoagulation. It binds and inhibits what? It's antithrombin. What's it going to bind and inhibit? Thrombin. Tamam. So it also inhibits factors 9, 10, and 11, right? So when you think about it, just think about antithrombin 3 is 9, 10, 11, and then obviously it's going to be factor 2 as well, because it's antithrombin, right? So what is the major drug that you give to activate antithrombin 3, basically? It's heparin. So this is how heparin works. Heparin doesn't work on its own by magical whatever. It binds to antithrombin 3 and makes it like 1,000 times more active, right? And then you have others. So you have antithrombin 3 naturally. What else would you have? You have protein C and protein S. Protein C and protein S are vitamin K dependent anticoagulants. And the important thing to know about them is that protein S is merely a cofactor for protein C, right? So you have protein C, and protein C goes, so protein S helps protein C, and protein C goes and stops factors 5, 8, and fibrinogen, yeah. So fibrinogen is before it becomes fibrin, and factors 5 and 8 are what? They're the cofactors. Remember? They're the cofactors for the coagulation. 8 helps 9 to get to 10, and 5 helps 10 to get to 2, or to activate 2. All right, so we have that, okay? You want to talk about fibrinolysis. Actually, before we talk about that, let's. I'm going to make a quick connection with this. I mean, yeah, it's the same thing, fibrinolysis, right? So we talk about TPA. When you talk about fibrinolysis, you're lysing the fibrin. What do you need? You need TPA is what's usually given, in cases of stroke, in cases of an MI sometimes, Dortinidin and all that stuff, right? So you have the tissue plasminogen activator, TPA. It's released from the endothelium, and we'll talk about things that are released from the endothelium in a second. You'll understand how to connect it. But we talked about protein C, right? Protein C degrades 5, 8, and 1A. TPA degrades 5, 8, 1A, and 1. Because the only thing that's the difference between them is that TPA actually breaks down the fibrin clot itself, while protein C breaks down everything that makes the fibrin clot before it becomes a clot. So it's the same effect. But we don't give protein C for a clot, for an MI. We give TPA because protein C doesn't break down fibrin. It breaks down fibrinogen, while TPA breaks down fibrin. Okay. And then you have other fibrinolysis like plasmin. And plasmin, we're literally talking about tissue plasminogen activator. And when fibrinogen becomes fibrin, plasminogen is going to become plasmin. And plasmin is the actual thing that breaks down the fibrin clots, right? To be more specific, plasmin breaks down fibrin, fibrinogen, 5 and 8, like we talked about. Remember? TPA. And then you have a regulator, right? Because you have this very good fibrinolysis mechanism, right? Plasmin. But at the same time, you want something to counter-regulate it, because you don't want it to go insane and break down all the clots in your body, because then you'll bleed to death. So the endothelium as well has a natural inhibitor of plasmin called alpha-2 antiplasmin. Simple, you have antithrombin, plasmin, antiplasmin. Rawa, ça va, latif. Remember how we talked about the endothelium? The endothelium produces 3 major things, and then 2 of them we already talked about, 1 we'll talk about in a second. And these are TPA, as you know, alpha-2 antiplasmin, to reverse or to counteract TPA, and then you have prostacyclin or prostaglandin I2. Prostacyclin is basically the same thing as the opposite thing to thromboxane A2. So when you think about thromboxane and prostacyclin, and we'll talk about these in a second right now, prostacyclin is from the endothelium, thromboxane is from platelets. So when something is from the endothelium, it's going to want to vasodilate, and it's going to want to decrease platelet aggregation, and it's going to want to increase CAMP in platelets, right? So basically it decreases platelet aggregation and increases CAMP in platelets. I'm assuming that makes them less active. I don't know. And then you have promotes vasodilation. Thromboxane is from platelets, and it's going to be like, hey man, I'm going to increase platelet aggregation because you decreased it. I'm going to vasoconstrict because you vasodilated. And I'm going to trigger the release of calcium in platelets. And the release of calcium in platelets exposes GP2B3A. And what does GP2B3A do? Exactly. It's like, I don't know exactly. But yeah, GP2B3A basically helps connect platelets together. Cross-linking. Okay. Also, it activates GP1B, which is the platelet to collagen binding. All right. Anyway, so you have factor, and this is like just quick bullet information you should know and you should have memorized for the exam. The shortest half-life of all factors is factor 7. So when you want to check for liver function, this will come way later. But when you want to check for liver function, one of the things you check for is INR and PT. Because remember, tissue factor F, and 7 are like opposite. So tissue factor and factor 7 are the extrinsic. The extrinsic don't have too many letters, so it's only going to be PT. And what do you give those extrinsic ones? A shunned drug, it's just like with a lot of side effects and very dangerous. It's not really that dangerous, but warfarin, all right? So there's that. The cofactors are what? Factor 5, factor 8, and you forgot one, factor 13 that helps cross-link fibrin together, all right? So factor 5 and factor 8 are called the labile factors. And what labile means basically is that they lose their activity in stored blood. But they're not lost in FFP, fresh frozen plasma. We'll talk about fresh frozen plasma. I'm pretty sure you've heard about it. Factor 8 as well is not synthesized in the liver. Factor 8, one thing that's very important for you to know, because we're going to talk about a deficiency of factor 8 in a minute, is actually factor 8 and von Willebrand factor are produced by the endothelium. Remember how we talked about TPA, antiplasmin, and prostacyclin? Another two that are produced by the endothelium are von Willebrand factor and factor 8, and these are always together. Always together. You have vitamin K dependent factors, which is 1972, protein CS. 1972 is 10972, and CNS, or CNS as you know. Okay, let's just say you gave warfarin, right? And warfarin depleted your vitamin K levels too quickly. The patient cannot coagulate, and basically you're going into DIC. You want to reverse the warfarin. You want to increase vitamin K. What do? You give vitamin K. But the problem with vitamin K is vitamin K comes in an IV form that takes 12 hours to start effect and 24 hours to take full effect, which means من هون لا يصير full effect البيشنت أو half effect حتى البيشنت راح يموت. So what am I going to do? I need to find something that gives them the factors quickly. And what is that usually? FFP. FFP takes immediate effect after infusion, right? But the problem with FFP, what does FFP stand for? FFP is fresh, frozen plasma. And you can't give something frozen to the patient. And how long does FFP need to be heated or to be prepared, let's just say, to be thawed, to be exact, is 2 hours, which means that's also too much time, too much, no time. We need to get to the patient quickly. So, also, what does FFP have? FFP is all the factors, albumin, and von Willebrand factor, right? So that's a side note. But yeah, what's something that can act quicker and it takes less time to be prepared? Prothrombin complex. And remember, prothrombin complex is like PTC. It's like that triangle we talked about, where 10 needs 5 to activate 2. So, or 5 helps 10 activate 2. 5, 10, 2. Yeah. Whatever it is, however you get to decide it, that's what it is. Prothrombin complex is 10, 5, 2. And then you have platelet factor 3 and calcium, right? Because calcium helps platelets, remember that. Okay, so PCC, or prothrombin complex, I like to write it as PTC, just makes me remember easier, takes 30 minutes to take effect, which means, it immediately takes effect, but it takes 30 minutes to prepare. So vitamin K comes in IV, 12 hours to take effect, 24 hours to be fully in effect. FFP, fresh frozen plasma, needs 2 hours to be prepared, but once it's given, it's immediate effect. And then you have PCC, prothrombin complex, or K-Centra. That's what they call it, I don't know. The effect is immediate, but it needs 30 minutes to be prepared, which is more reasonable than 2 hours and way more reasonable than 12 hours, right? So, okay. This is very important for you to know, and you'll know why it's important for you to know in a minute. But the normal half-life of the cells in the blood, right? So you have RBCs, 120 days, that's fine. You have platelets, 7 days. That's very important to know. Platelets, 7 days half-life. And polymorphonuclear cells, PMNs, are 1 to 2 days usually. Okay? Coagulation factors, you have, as we talked about, you have FFP, fresh frozen plasma, all the coagulation factors, protein C and S, and antithrombin, as well as albumin and von Willebrand factor. There's also cryoprecipitate, which is basically endothelium factors, right? And when you think about endothelium factors, what do you think about? Remember, you have endothelium gives prostacyclin, TPA, antiplasmin, but what else does the endothelium give you? It gives you factor 8 and von Willebrand factor. So when you think about the cryoprecipitate, it sounds like cryoprecipitate, like it's something like, ice and stuff and whatever. It's like fresh frozen. No, not really. It's the endothelium factors, right? And it's very important to give, because von Willebrand factors and factor 8 have 2 distinct diseases. You have von Willebrand disease and you have hemophilia A, which is factor 8 deficiency. And by the way, it also has high levels of fibrinogen. That's the cryoprecipitate. But that's not the most important thing about it. The most important thing about it is von Willebrand factor and factor 8. Okay. It's released, von Willebrand factor and factor 8 can be given by cryoprecipitate, or they can be stimulated out of the endothelium, right? So endothelium is producing, but it's not producing the amount you want it to. What do you give? You don't give cryoprecipitate, you give desmopressin, or DDAVP. Desmopressin and conjugated estrogens are basically cause the release of von Willebrand factor and factor 8 from the endothelium, right? And then you have coagulation measures. You have PT, you have PTT, and you have INR. PT and INR are usually together. وزي ما حكينا, PT it measures factors. The most important factor it measures is 7, but as do all other ones, it measures factor 10, 5, and 2. Because remember, 10, 5, 2, 1 are in the common pathway. They're not in the extrinsic or intrinsic. And once you give warfarin, because remember warfarin is shunned, so it's extrinsic, and the extrinsic has less letters, so less letters is only PT. So when you give warfarin, you increase PT, and hence increasing INR. And the INR you wanted during this is, during given warfarin, is between 2 and 3, okay? And then you have PTT. PTT measures most factors except factor 7 and factor 13, because factor 7, as we said, is an extrinsic. Factor 13, آخر إشي, it helps with fibrin cross-linking. Okay. It measures it measures heparin anticoagulation. And when you want to give warfarin, you want INR between 2 and 3. And when you want to give heparin, you want PTT between 60 and 90 seconds, right? Okay. So let's talk about, let's see how many pages we have left. Okay, not too many, we got this. All right. So you have activated clotting time. The only thing you should know about it is that you want it when you're giving routine anticoagulation, you want the activated clotting time between 100 to 150 and 200 seconds. The only time you want it to be more than 400 seconds is when you're doing cardiopulmonary bypass for any sort of surgery, for cardiac surgery, pulmonary surgery, whatever reason you need to do a cardiopulmonary bypass, you need the activated clotting time to be more than 400 seconds, right? And then you have two distinctions in terms of, or contraindications for INR. Remember, INR between 2 and 3. If you wanna give warfarin, you wanna keep it between 2 and 3. If INR is over 1.5, that means it's a relative contraindication to performing any surgical procedure, right? If the INR is over 1.5. Because that means it's like there's a very good chance this guy's going to bleed out on the table and I'm not going to be able to do anything about it. And then you have the INR of over 1.3, not 1.5, 1.3. 1.3 is a relative contraindication for 3 things, right? Central line placement. Because central line placement, you're going to like a central line, it's not like an IV access. You have percutaneous needle biopsies. So remember, central line, biopsies, and eye surgeries. I don't know why eye surgeries. Doesn't make sense to me, but it is what it is. Eye surgeries. 1.5 for any surgery, it's a relative contraindication. 1.3 is a relative contraindication for eyes, central line placement, and biopsies. To be more specific, percutaneous needle biopsies. So bleeding time obviously is a test for platelet function. Thromboelastography. Thromboelastography, I genuinely I need you guys to look at this at the end when you're about to take the exam, just to remember it, because you're going to keep forgetting it. And the important part about it, I'm just going to give you quick headlines. It helps to actually look at the diagram, but let's just talk about I'm going to give you each one and the treatment for it. You have elevated R. So R is increased. R is reaction time, right? If the reaction time is increased, you need to give FFP. If elevated K or K time, you need to give cryoprecipitate. Remember, cryoprecipitate is the tissue or the endothelium factors, which are von Willebrand factor 8 as well as fibrinogen. Low angle, so the clot kinetics are off, you also give cryoprecipitate. At low maximum altitude, you have to give platelets and desmopressin. Desmopressin causes the release of von Willebrand factor and factor 8 from endothelium. Yes, sir. Okay, and you have high lysis 30. So lysis 30 minutes after the clot formation, basically. That means there's a lot of fibrinolysis. And if you want to stop fibrinolysis, we'll talk about it now, you have to give aminocaproic acid or tranexamic acid. Honestly, I remember tranexamic acid more than aminocaproic acid, because I remember when I used to study a postpartum hemorrhage, tranexamic acid is a line for it. They even give tranexamic acid for a lot of surgeries now, in terms of to stop or to minimize bleeding, right? So you have aminocaproic acid and tranexamic acid, or tranexamic acid. Tranexamic, yeah. All right, so you have bleeding disorders. Let's take a second. take a breath, and talk about bleeding disorders. All right, we're going to run through them because you know all of this. Trust me, you know all of this. You have von Willebrand disease. Von Willebrand disease is the most common congenital bleeding disorder. And this is a question. This could easily be a question. Most common congenital bleeding disorder is von Willebrand disease. And von Willebrand disease, it usually presents as epistaxis, right? There's 3 types to von Willebrand disease. Type 1, 2, and 3. All right? 1 and 2 are autosomal dominant. Type 3 is autosomal recessive. And remember, whenever something is autosomal recessive, usually means it's bad. It's like terrible, barely compatible with life. 1 and 2, dominant, can't be compatible with life, right? Makes sense. So as you know, von Willebrand connects GP1B receptor on platelets to collagen. So that's how you connect platelets and collagen. Usually the PT is normal, but as we talked about, von Willebrand factor comes with factor 8, and if von Willebrand factor is decreased, factor 8 is going to be low. Could be low. Let's talk about it. Could be low, which means PTT is going to be low. Remember, because PTT is 12, 11, 9 through 8, activating 10. So 12, 11, 9, 8. All right. And how do you actually test for that? Because PT can be normal and PTT can be normal as well, right? Both can be normal. But how do you test for it? You test for bleeding time, the ristocetin test, right? So if that's long, if that's off, that's when you know, okay, it's probably von Willebrand disease. And there are 3 types for it. As we said, 1 and 2 are dominant, 3 is recessive. 1 is reduced quantity. So when you have decreased quantity, you want to give a recombinant factor 8 or von Willebrand factor. But you could also give cryoprecipitate easily. But since the endothelium is already producing those, you just want it to produce more. Remember how we talked about that? So what do you give when you want it to produce more? Desmopressin, DDAVP, and estrogens, but let's focus on desmopressin, right? DDAVP. Factor 2 is not reduced number, but defect in the molecule itself, which means it doesn't work well, which means it doesn't connect the GP1B receptor on platelets to collagen. So you can't just simply fix it, or it's like the amount is there, it's not working well. So you need to either give recombinant von Willebrand factor, so basically a proper functioning one, which is obviously going to wash out and then you need to give more. Or you can give cryoprecipitate, or you can give DDAVP, but to be honest, that's not very useful. It's either cryoprecipitate or recombinant, you know what I mean? Because cryoprecipitate is just you giving von Willebrand factor, the same as recombinant, right? And then you have type 3. Type 3 is autosomal recessive, so that's the terrible one, right? And there's a complete von Willebrand factor deficiency. It's not there, right? So the only thing you can give is cryoprecipitate and recombinant. You can't give DDAVP, because if you give DDAVP, you're stimulating the endothelium to produce von Willebrand factor, but the endothelium is not producing it in the first place. There's a defect, there's an issue with it that doesn't produce it at all. So you can stimulate it all you want, you're not going to be producing it, which means you're going to give cryoprecipitate and recombinant, factor 8 and von Willebrand factor. All right, so there's that. All right, this is von Willebrand disease. Hemophilia A and hemophilia B. Hemophilia A is very simple, right? It's just factor 8 deficiency. There's a song I memorized for steps. It was the Itsy Bitsy Hunter's name was Les Fabry. He shot the Mankeys, Wasp, and G6B. Up came Bruton, what a douchey guy. A and B are X-linked, don't forget DI. So these are the names of the diseases that are X-linked recessive, right? So you have A and B are X-linked. Remember in the song? So A and B are X-linked, don't forget DI. A and B are X-linked. What are A and B? A and B are hemophilia A and hemophilia B. So they're sex-linked. Recessive. The nice thing about hemophilia A and B are they're much more easier to differentiate than other platelet issues, is because it's not a platelet issue. It's a factor issue. And any factor issue does not cause as much, or does not usually present with cutaneous symptoms, right? So it's not skin, right? It's deeper tissue. So the most common presentation or symptom is hemarthrosis, where there's blood in the joint, right? Most commonly in the knee joint. Okay, so I'm going to perform some sort of surgery, because this is obviously Absite, So I'm going to perform some sort of surgery for a patient with hemophilia A. How should I go about it, right? Like, do I need to give him, how much do I need to give him, right? Pre-operatively, I want the levels to be like a normal human being. I need it to be 100% pre-op. But post-op can drop from 80 to 100%. So anywhere from 80 to 100% is fine for the first 2 weeks after surgery, right? And then I want to check the PTT, because remember, factor 8, PTT. I want to check the PTT every 8 hours after surgery. So 3 points you need to know. Pre-operatively, I need the factor 8 to be 100%. Post-operatively, for 10 to 14 days, is going to be 80 to 100%. And Q8 hours, so every 8 hours, I'm going to be checking PTT for this patient. The nice thing about it is that you can also examine in terms of like children, right? When you want to think about it, you want to think about, so why doesn't a newborn like bleed during circumcision? A newborn with hemophilia A, why doesn't he bleed during circumcision? It's because factor 8 can cross the placenta, which means he's going to have enough factor 8 to like withstand the first, I don't know how long, until like the circumcision is done. But afterwards, it's gonna drop. He's not gonna be making new ones, so it's gonna drop, and that's when the symptoms begin. Obviously, a very important point: when you have a hemophiliac joint bleeding, please do not aspirate. Do not aspirate it. When you want to think about it, when you're sure this is blood, and this is obviously you can tell with imaging or ultrasound and whatever. Do not aspirate it. And other symptoms can be epistaxis, intracerebral hemorrhage, and hematuria, obviously, because these are all, epistaxis is like cutaneous or a mucoidal, but besides that, it's the idea of like deeper tissue when you want to think about factors. And the treatment for a hemophiliac joint bleeding is ice, and you want to keep the joint mobile with exercises, and you want to give factor 8, obviously. That makes sense. Or cryoprecipitate, for that matter. Right? So there's that. Hemophilia B is also called Christmas disease. I kind of forgot why that is. Not really important. You have sex-linked recessive, as we memorized. And then you need to check the levels pre-op and post-op. Remember, in pre-op for hemophilia A is 100%, 80 to 100 for 10 to 14 days, and Q8 check PTT. For hemophilia B, you want it obviously 100% pre-op, but I am willing to go down to 30 to 40% after 2 to 3 days after surgery, right? So pre is 100, post for 2 to 3 days is 30 to 40%. And obviously, again, prolonged PTT, because factor 9 is missing in this one. Same treatment, you either give factor 9 or you give FFP. In hemophilia A, you can give cryoprecipitate, but in hemophilia B, you have to give FFP. All right, so now we finished the factor ones. Let's talk about the platelets real quick. Platelets, as we said, cutaneous, so that's bruising, epistaxis, petechiae, and purpura. There's acquired and there's genetic or hereditary thrombocytopenias. In the case of acquired, the first thing you want to put in mind is heparin-induced thrombocytopenia. These are the more common ones. And then we'll talk about it in a second. But it can also be caused by H2 blockers and heparin. It makes sense. Yeah, heparin makes sense. But H2 blockers is just like, I need to scratch my brain for that one. Doesn't really matter. Just know it. All right. So you want to talk about the Glanzmann and Bernard-Solier thrombocytopenia. I think it's a misnomer to call it a thrombocytopenia because it's not really thrombocytopenia. The platelets are there. The Glanzmann is like Glanzmann is like a big name, Bernard is a small one, but Glanzmann is big. So when you want to think about big, you want to think about the bigger complex. You have not GP1B. Glanzmann is GP2B3A. And when you have a GP2B3A deficiency, the platelets cannot bind to each other. Simple as that. The treatment for that, by the way, is platelets. Bernard-Solier, just remember Bernard B. So GP1 Bernard, GP1B. So when GP1B is missing, platelets cannot bind not to each other, but to collagen. The treatment obviously is also what? Platelets. Another cause for acquired thrombocytopenia is uremia. And what uremia does is, like, especially when BUN is over 60 to 80, like, besides encephalopathy and all of that, you want to think about how it inhibits platelet function. And it also causes, sorry about that, it also mainly inhibits the release of von Willebrand factor, right? So uremia inhibits von Willebrand factor. The treatment for uremia is depending on the case. So if you have moderate to severe bleeding, you want to be giving cryoprecipitate. A very key, like a first-line treatment for uremia in by itself is hemodialysis. However, if you have a lot of inhibition of von Willebrand factor, I cannot wait for the hemodialysis to work so the hemostasis can occur and the patient can be stabilized. I need to give desmopressin so the endothelium can release more von Willebrand factor, overpowering the uremia's inhibiting release of von Willebrand factor, if that makes sense. And then you have HIT. HIT is heparin-induced thrombocytopenia. Basically, if a patient has HIT, he has antibodies to heparin. So when heparin comes, instead of attaching to antithrombin 3 and activating it, which blocks which factors? Antithrombin 3. So it blocks thrombin, obviously. And then it blocks 9, 10, 11. Remember that. So thrombin and then 9, 10, 11. Thrombin is 2. Anyways, so instead of activating antithrombin 3, it's going to form an antigen-antibody complex and then attack what? Attack the platelets, which is going to cause platelet aggregation and thrombosis, as well as thrombocytopenia. So platelet aggregation and platelet destruction of surrogate. Mema. So how do you, okay, but how can I really test for it? I can't just test for it that easily. Oh, actually, before that, why would I even attempt to test for heparin-induced thrombocytopenia? The first thing there are three criteria, or three things you should keep in mind that are alarm or red flags. So, for you to test for it, they're okay, hey, you need to test for this. Number one is the platelet count being less than 100. Number two is the platelet count dropping by more than 50%, from the time of admission. So if at the time of admission it was 250, now it's 125 or 120 or 110. It's more than 100, but it dropped more than 50% from time of admission. That means there's something wrong. It's probably I need to check for HIT, right? And then you have thrombosis on heparin. So I have a patient in the ICU. I'm giving him heparin, and then this guy just develops a DVT, right? Or a PE, or an MI, or a stroke. But he's on heparin. How? This is an indication for you to test for heparin-induced thrombocytopenia. But how do you test for it? Simple. You can either initially screen by for the heparin antibodies we're talking about, because remember it's antibodies for heparin, through the ELISA testing, or you can check to confirm serotonin. I love this name, by the way. Serotonin release assay. It's I don't know why, but why would heparin release serotonin? It's just I know it makes sense, but it just sounds nice. Serotonin release assay. And that's how you confirm heparin-induced thrombocytopenia. Also, at all risks, at all costs, at all whatever, do not give them platelets. Because remember, there is thrombosis as well as platelet destruction. Which means if you give platelets, more are going to be destroyed, but some of them can increase the thrombosis, which can cause worsening thrombosis symptoms, All right. And then you have DIC. DIC is disseminated, so everywhere. Intravascular, so inside the vessel, coagulation. So when you want to think of a DIC, to be completely honest, everything is fucked, right? You have increased PT, PTT, decreased platelets, low fibrinogen, high D dimer. This is the key. High D dimer, right? High D dimer. Very important. Oh, one thing when we go back to HIT, sorry about that, sorry for the confusion. The treatment, so I diagnosed heparin-induced thrombocytopenia. What do I do? Obviously, when you want to treat it, you're going to stop heparin. That makes perfect sense. But what also are you going to do? I can't just not coagulate, not anticoagulate at all. I need to give something. And what you give is argatroban. Argatroban is a direct thrombin inhibitor. We'll talk about argatroban in a second. But for now, all you need to know is that you give argatroban for a hit. Okay, so DIC again, it's often initiated by the release of tissue factor, increased PT, PTT. The most important one is what? High D dimer, Mia. And you need, the treatment for it is not really anything. You need to treat the cause, because DIC is not a disease in by itself. It's a complication of something, right? Okay, so remember how we talked about platelets having a half-life of 7 days? Platelets, or platelet antagonists, or antiplatelets, basically, are what? Are aspirin and clopidogrel, right? So these are the major ones. So when do you want to stop, in order for the patient not to bleed on the table in surgery, or too much, or even after, how long would you need to stop antiplatelet therapy for platelets for new platelets to arrive, or to be created, or to form? 7 days, because that's the half-life. Which means I need to stop aspirin and clopidogrel, Plavix, 7 days before the surgery. Aspirin, as we all know, inhibits COX in platelets and decreases thromboxane. And clopidogrel is an ADP receptor antagonist. It's a treatment for bleeding and platelets. Okay, so treatment for bleeding is platelets. I mean, not the treatment for bleeding and platelets. The treatment for bleeding is to give platelets in these two. And all right, so let's just say I have a coronary stent, right? And PCI, percutaneous catheterization. Patient comes in and he needs to stop Plavix for elective surgery. But at the same time, I can also stop anticoagulation. Remember how with HIT I give argatroban? In the case of this, of having to stop clopidogrel, what I can give in its place is a GP2B3A inhibitor called iptifibutide. It's basically an integralin. Iptifibutide, GP2B3A inhibitor. Just remember, argatroban for HIT, iptifibutide for clopidogrel stoppage. And you have Coumadin. For some reason it's called Coumadin, which is, just call it warfarin, dude. Okay, you need to also stop that 7 days before. The treatment for it is, as we said, vitamin K, but last you start with PCC and then FFP, and you give vitamin K. Obviously, you have to give it, but it's for the long-term management, not long-term, but after 24 to 48 hours. But immediate is PCC or FFP. So, okay, just quick notes you need to know in terms of surgeries. How much do I need? What is the minimum amount of platelets I need to go into surgery, right? It's like, oh, this patient is a good candidate. I'm fine with it. I can live with that. 50,000. Anything less than 50,000, I'm not going to be comfortable going into surgery. I'm talking as if I'm a surgeon. Okay, inshallah, lesh la. And then you have over 20,000 after surgery. If it's over 20,000 after surgery, you're also fine. You're in the safe range. One thing you should know is in prostate surgeries, urokinase can be released, and urokinase does the same thing as tissue plasminogen activator. It activates plasminogen, becomes plasmin. يعني ايش هيصير؟ Thrombolysis, hence bleeding. The treatment for bleeding is what? Remember, I said the postpartum hemorrhage. I said there's tranexamic acid, and then there is the other weird one. For some reason, reminds you of like Leonardo DiCaprio. Caproic acid. Aminocaproic acid, which basically inhibits fibrinolysis. So the fibrin clot stabilizes, which means no bleeding happens. What else? This is all pretty much the same. Okay. Hypercoagulability disorders. Right? So this is a big one. But it's very simple. It's very quick. We'll run through it. Hypercoagulability means there's too much coagulation happening. Right? And it can present as arterial or venous thrombosis or emboli, DVT or PE or stroke. The most common one, congenital that is is factor 5 laden mutation, right? And it accounts for 30% of spontaneous venous thrombosis. So what happens really with factor 5? Factor 5 laden mutation. Remember how we talked about protein C basically going to factor 5 and 8 and being like, hey man, chill. You're not going to coagulate anymore. Factors 5, in this case, is resistant to protein C, which means protein C can come and stop factor 5 from coagulating. And factor 5 is going to be like, nah, I'm coagulating. So there's a resistance to activated protein C on factor 5, right? Which means I need to give heparin. And by the way, for everything we're going to talk about right now, it's the treatment is heparin and warfarin, right? You want to anticoagulate because this is a pro or hypercoagulable state. So factor 5 is the deficiency or the resistance of factor 5 to protein C, factor 5 laden deficiency or mutation. All right, you have hyperhomocystinemia. Hyperhomocystinemia happens with vitamin B12 and folic acid deficiency, causing a hypercoagulable state, which basically means just give them folic acid and vitamin B12. Prothrombin gene defect G20210 or 20210, 90210. This is also you treat it with heparin and warfarin. Protein CS deficiency, you give heparin and warfarin. Antithrombin 3 deficiency. So when you give heparin, it binds to antithrombin 3. Antithrombin 3 stops thrombin, which is 2, and then 9, 10, 11. So when you don't have antithrombin 3, and then you give heparin has nothing to connect, to bind to, which means heparin al-fadi. It's not going to work. And it's obviously, this is not something that's congenital. It can develop after a few times of heparin exposure. And the treatment for it is antithrombin 3 concentrate, recombinant antithrombin 3. What also has antithrombin 3, if you remember, as well as albumin, as well as other stuff? FFP. FFP has antithrombin 3, so you can give FFP as well. But you can't just give FFP, you have to give heparin and warfarin as well. Not together, you bridge. There's this fibrinogenemia and this plasminogenemia. Obviously, same thing. Whatever. Give heparin and warfarin. You have a cool one, and the book doesn't go into detail with it, but I really like it. Polycythemia vera. It's basically the bone marrow going into overdrive, producing everything, overproduction, and you can get when the blood thickens, when there's too much in the blood, it gets very viscous. It causes thrombosis. So what is something I'm willing to accept when it comes to polycythemia vera? Because I can't just treat it cure it, right? I have to give a certain level where I'm okay with this. As long as hematocrit is less than 48, and as long as platelets are less than 400, before surgery, obviously, not in general life, I'm willing to go into surgery. Hematocrit of 48, platelets of 400, come here, let's go. Let's hit it, right? And the treatment for it, let's just say the hematocrit is too high, the platelets are too high, it's phlebotomy, aspirin, and hydroxyurea, right? Antiphospholipid antibody syndrome. Literally what you need to know is this, right? It's increased PTT while clotting, right? So remember how there's HIT is he's on heparin, but he's also clotting. In this case, antiphospholipid antibody syndrome is literally the PTT is high, but why? So PTT is high, that means there should be a lot of bleeding, but the patient is clotting. How? Right? So the symptoms for it are DVT or PE, loss of pregnancy, very commonly in that, and may have symptoms of lupus, right? And it's caused by, obviously, it's antiphospholipid antibody syndrome. It's caused by antiphospholipid antibodies. More specifically, anti-lupus antibodies and anti-cardiolipin antibodies, right? And the treatment, the diagnosis is a prolonged PTT, and one fun or interesting caveat about it is that it can cause a false RPR test. An RPR test is the rapid plasma antigen test, rapid plasma reagent test, sorry, and that's for syphilis. So you can have antiphospholipid antibody and you can be accused of having syphilis. Big problem. Okay, the treatment for it is what? Heparin and warfarin. I was going to say aspirin, no. Heparin and warfarin. All right. Acquired hypercoagulability, there's obviously these are all congenital stuff. The acquired is some smoking, malignancy, inflammatory states, post-op patients, pregnancy, rheumatoid arthritis, OCPs. The only ones you should remember that make sense like immediately is tobacco, malignancy, pregnancy, OCPs, and post-op patients. There's obviously IBD, myeloproliferative disorders, infections, inflammatory states. Sure. Okay. Remember how cardiopulmonary bypass, we talked about the activated clotting time needs to be more than 400 seconds, and the regular, this is for cardiopulmonary bypass, but in general, the activated clotting time should be, for patients who are obviously anticoagulated, should be between 150 and 200. Okay. Warfarin-induced skin necrosis. The only thing you should know about is that the half-life of protein C and S are short, and a patient with relative protein C deficiency is highly susceptible for it. And what literally happens is skin necrosis after you give warfarin, right? It's a hyperthrombotic coagulable state, right? And the treatment for it is heparin, if it occurs, and then you place the patient on heparin before starting warfarin. This is how you prevent it, right? So instead of going straight, why don't we go straight into warfarin? We bridge with heparin, which basically means we give heparin for a while until we get the INR I think we want or whatever it is, and then we go to warfarin. That way we prevent warfarin-induced skin necrosis. Okay, so we're talking about hypercoagulability and everything, and we forgot to mention the very important point, or the key element in the development of venous thrombosis, to be specific, which is Virchow's triad. Virchow's triad is stasis, endothelial injury, and hypercoagulability. The arterial thrombosis is not a triad. This is one thing. It's not stasis. It's not hypercoagulability. It's endothelial injury. So arterial is only endothelial injury. Venous is stasis, endothelial, and hypercoagulability. And speaking of hypercoagulability and Virchow's triad and venous stasis is deep venous thrombosis. So DVT. The only thing you know about all of this, right? And it doesn't matter. The only thing you should know about in terms of duration to anticoagulate for DVTs is the following. There's two categories. There's 3 months, there's two durations. There's 3 months or lifetime. 3 months is for a first-time calf DVT or a provoked proximal DVT or PE. Proximal is basically let's just say above the lower limb, right? So provoked can be something post-op, can be smoking, can be inflammatory disease, can be IBD. Remember the ones we talked about about the malignancy and OCPs in pregnancy? This is provoked. So if it's either provoked or a first-time calf DVT, you only anticoagulate for 3 months. If it's a second-time calf or an unprovoked proximal DVT or PE, وقتها you give lifetime. And obviously, if it's cancer or hypercoagulable state, you anticoagulate until that is treated. But 3 months for first-time calf or provoked, lifetime for second-time calf or unprovoked. An IVC filter is indicated for patients with either a contraindication to anticoagulation, obviously, a PE on anticoagulation. So anticoagulation is contraindicated, or I gave anticoagulation and it didn't work, or a recent pulmonary embolectomy. There's this thing about free-floating IVCs and all that stuff, but it's controversial. I don't want to mention it. You have recent pulmonary embolectomies. You basically place the IVC below the renal veins, because you don't want, if it's above the renal veins and a DVT is coming from lower, it can go to the renal vein and cause big problem for the renal, right? Renal vein thrombosis. Okay, so you have a PE with a filter. Okay, so I have my filter, and it's below the renal veins. Everything's good. Everything's chilling. We're supposed to be good, and then I get a PE. Where is it likely from? Not from the IVC, from the SVC. So not from the inferior, from the superior vena cava, or from the IVC above the filter, which is very unlikely, or gonadal veins. And I think the gonadal veins, it's because, although they're lower, but it's because they connect to the IVC at a higher level, I guess. All right, real quick. PE. You give heparin bolus for PE. You do not wait for CT scans, especially if you're sure and if the D-dimer is positive. The most commonly, the most common region that a PE comes from is, so a DVT that develops into PE basically, is the iliofemoral region. That's the most common. That's the most important thing you should know. Okay, so hematological drugs. There's procoagulant, there's anticoagulant. Procoagulant makes you stop bleeding. Anticoagulant makes you stop thrombosing, basically. So procoagulant is, as we said, aminocaproic acid, blocks plasmin, and then you have tranexamic acid, obviously. And it's given for a thrombolytic overdose. So I give too much heparin, for example. Actually, heparin has a different one, but we'll talk about it. Okay, so anticoagulation agents, there's warfarin. It stops the decarboxylation of glutamic residues. مش مهم. The half-life of warfarin is 40 and it's 40 hours, and it's contraindicated in pregnancy. And then it goes talking about, okay, the NOACs. So I think it's called what is it? Something oral anticoagulants, right? Or novel oral anticoagulants. And when you want to think about them real quick, you have dabigatran. Dabigatran, I think everyone knows it. It's given for AFib. Half-life is 12 hours, not really important. The only thing you should know about dabigatran is it's also called Pradaxa. So Pradaxa, and with XA, means that the antidote for it is called Praxbind. It's an idariruzumab, or idariruzumab. It's basically an antibody for it. It binds to it and it stops it. So the dabigatran, AFib, Praxbind, antibodies. And then you have apixaban and rivaroxaban. Apixaban and rivaroxaban are also given for AFib. They're also factor 10 inhibitors, and the antidote for them is Andexa. So apixaban and rivaroxaban are two. So apixaban and rivaroxaban, or Andexa. Or you have Andexa as the antidote, while dabigatran is Praxbind. Heparin basically is, when you give heparin, it's 60 to 90 minutes half-life. It's cleared by the spleen and macrophages. It works on fibrinogen. It works on thrombinogen, basically, which is inactivated thrombin 2A and 10A as well. While low molecular weight heparin only works on 10A. It does not work on 2A. It does not work on thrombin. The antidote for heparin is protamine sulfate, yes sir. If you give too much protamine, what happens? Hypotension and bradycardia. And long use causes osteoporosis and alopecia for heparin. And as we said, HIT medication, when you have HIT, you give argatroban. But let's just say argatroban is metabolized by the liver. So let's just say the patient has liver failure and he has HIT. What am I going to do? Not anticoagulate him? No. I'm going to give bivalirudin. Bivalirudin. Yes, sir. All right, so that's that. Kemas. That's about it. That's one more thing though. The contraindications to thrombolytic use, basically, there's absolute, major, and minor. You just need to know the absolute and major. The minor just kind of whatever. The absolute ones are active bleeding, right? When the patient bleeding, you don't want to make him to bleed more. Make him to bleed more. Nice. You don't want him to bleed more. A recent cerebrovascular or cardiovascular accident. I'm not sure which one they were talking about. But more importantly, neurosurgery less than 3 months. And then you have recent surgery less than 10 days. An organ biopsy, an obstetric delivery, a major trauma, uncontrolled hypertension, recent eye surgery, and peptic ulcer. Right? So these are the absolute and the major. Both of which I think are like almost the same, right? Because why would you want to give thrombolytics to a person with recent surgery, especially major? So there's neurosurgery less than 3 months, recent surgery less than 10 days, active bleeding, recent CVA or recent trauma or recent eye surgery. And the only thing that's kind of off from everything else is either uncontrolled hypertension or active peptic ulcer disease, which kind of makes sense. But besides that, that's chapter 2, Hematology, Absite.